My pleasure to introduce Grand Rounds, our first one of the new year. It's Innovations in Total Knee Arthroplasty. It's been organized by Stuart Michnick and our attendings with a lot of expertise in this topic that we'll be discussing it are Paul Manor and Adam Sassoon. And I've asked them to do it in a slightly different format this time, so it's going to be modeled on more of a rapid fire session where they're going to go back and forth and essentially debate each other, moderated by Dr. Michnick, and we'll be able to cover a little more ground that way. And all I ask, if anybody has any questions, do you guys want to do it in between each set, or do you want? Okay, so we'll do it in between, and I just ask that you either use the microphone or have the speakers repeat your questions so our people watching off-site can hear the questions. So Dr. Mitch.
Thank you, Dr. Chansky. So thank you everybody for coming this morning, and thank you for everybody who's at their home base watching online. As Dr. Chansky discussed, we're going to be talking about innovations in total knee arthroplasty, which is a topic that's up for debate. So we're thrilled to be able to do this in a pros versus con format. So I'm going to start each topic that we discuss and provide a brief overview of how the technology works. And we'll be having Dr. Manor and Dr. Sassoon provide their take in a pro versus a con fashion. So let's get started. The first topic we're going to discuss is computer-assisted navigation. And in traditional total knee arthroplasty, the surgery itself is dependent on the surgeon making intraoperative measurements to determine where the appropriate location for cuts, as well as positioning and sizing for the components are. And anytime we introduce surgeon measurement into our activities, we also introduce the element of error. So navigation is a way to try to increase the precision of our measurements to help increase the precision of the final product. So how does it work? In essence, using patient anatomic markers, we can create a virtual model of the patient's anatomy, which allows us to perform an intraoperative template, determining where the cut should be made as well as the component specifics. And then using that template can ensure that we have made the actual appropriate cuts. In order to do this, it requires a couple of things. Computer-assisted navigation, of course, requires a computer as well as a sensory input device, which in most cases is an infrared sensor or an accelerometer, which is the same type of accelerometer you have in your smartphones, which allows it to know where it is in space. And the surgeon undergoes the approach that is their preference and exposes the knee joint. Once the knee joint is exposed, we pin sensors onto the distal femur as well as the proximal tibia. And these are 2 points of reference for the computer. And a third point of reference is used in the form of a probe, a IR probe. And the surgeon will register different locations on the knee using this probe. So we'll register the medial femoral condyle, the lateral condyle, the intercondylar notch, as well as spots on the tibia, so this is the plateau, and even the malleoli. And doing this allows the computer to map out the anatomy with any sort of deformities, as well as the mechanical and anatomic axis. Once this is done, the surgeon intraoperatively is able to determine where the cut should be using the program in the operating room, as well as determine the sizes of the components themselves. And once this is locked in and everybody is happy with the appropriate positioning of where the planned cuts would be, there are cutting guides that have sensors attached as well. And these cutting guides will allow the surgeon to dial in the appropriate angles and positioning and compare them to the template to make sure they're in the correct place. And to bring that even further, the instruments, such as the oscillating saws that the surgeon uses, have sensors on them to provide another check to make sure that these are correct. And even the trials, once a trial is in place, you can trial the patient and range their knee with the sensors, which will provide you more objective measurement of the patient's range of motion as well as varus and valgus stability. So what I've discussed there is mostly the infrared-based way to undergo navigation. There is also accelerometer base, which is a newer technology that's being used. And this is one in which has similar principles to the infrared based. There are accelerometers both in the display console, which is this right here, as well as this reference sensor here. And these accelerometers are able to be used to determine where the cutting guides are in space. So using a combination of ranging the hip and the knee to provide a reference, as well as using a probe within the accelerometer attached to different portions of the patient's extremity, you're able to determine where the guide is in space, and the surgeon can dial that in to the appropriate position that they like before making the cuts. So that's a brief overview of this navigation, and I'd like to go straight into the pros versus cons. And to first discuss the pros and provide his insights on navigation, I'd like to bring up Dr. Sassoon.
Thanks, Stuart. So I just want to show my disclosures here. I'm a consultant for biocomposites. I have no relevant financial disclosures to the rest of this talk today.
Technology, what is that all about? Is it good or is it whack?
So today we're talking about technology and its applications in orthopedic surgery. And so one thing that I need to disclose too is sort of my underlying philosophy as it relates to technical advances in my field of work. And so based on my training, you know, I was always taught to never be the first or the last to adopt new advances. Okay, we've seen major pitfalls in that in orthopedic surgery, especially in the field of arthroplasty with metal-on-metal implants, some modularity implants. And I think that it's important for residents to remember that, you know, surgery is not an easy thing to do. And anyone that promises you a very foolproof or simple way of doing things is likely trying to sell you something. And I also think that, you know, moderation is the key, especially when, you know, working with new technology. And so the main questions that we seek to answer when evaluating new technology is, does it improve patient care, okay, in clinically significant measures? So is it actually providing functional benefits for our patients? And does it justify its own cost, okay? Because we live in a world where that's becoming more and more important, and it affects reimbursement and how we take care of population-based problems. So computer navigation in total knee arthroplasty is something that I support. I support the use of computer nav as a versatile tool in complex total knee arthroplasty, so in the setting of very large deformities that need to be corrected, or when standard instrumentation can't be used. I don't think it's a magic bullet that we need to use every time. You know, if you're a well-trained arthroplasty surgeon, you should be able to put components where they need to be, but I think that it does offer a way to improve accuracy and fidelity in bony resection. And so, as Stuart alluded to, there's two types of navigation. There's the traditional infrared sensor-based techniques and the accelerometer-based systems. Now, I'm going to be focusing most of my discussion on the accelerometer-based systems because that's where I have most of my experience. But also, if you look at studies comparing the two, they've been concluded to be equivalent, both in respect of achieving overall limb alignment, tibial component alignment, femoral component alignment, and also have been shown to be somewhat faster than the large console. I also like it because you don't have to put any pins outside of your area of dissection, so you're not needing to inflict any further morbidity on your patient. And then from a cost perspective, I also find it to be much more efficient than large console computer-based programs. There's less in terms of servicing costs, software costs. This is a one-time fee per surgery that you see with the other navigation systems, but you avoid all of the main big-ticket purchases that we see with some of the other systems. So why are we talking about navigation, and why is it important in total knee arthroplasty? That's because alignment is important in total knee arthroplasty. So if you look at outliers in tibial component positioning, varus angulation of 3 degrees or more correlates with an increased failure rate of implants. And that is a huge concern as it relates to the growing economic burden of total knee arthroplasty revision. Here's an example of a gal that was sent to me. She's a very large gal. You can tell by the soft tissue envelopes around her legs. And she was put in varus, and that caused her component to further subside and fracture her tibia as that force was accentuated during weight bearing. And so she went on to have a revision in a sort of semi-emergent fashion because of her fracture of the medial plateau of her tibia. But you know, this is a high-risk surgery in a patient that had a lot of comorbidities. So the pros about computer-assisted and accelerometry-based navigation, I think, especially with the accelerometry-based navigation, you can use it with any knee system. You can use it in any patient. It allows for real-time fine-tune adjustments in the operating room that custom specific jigs does not allow for, which we'll get into. It does not require any additional instrumentation. It's less invasive, so there's less blood loss. You don't violate the intramedullary canal. There's a less emboli burden. And it doesn't require any additional imaging, which some of the other technologies we're discussing today do. It does increase the cost of surgery, and in our hospital, it's roughly about $850 additional per case where we use the accelerometry-based navigation. This is a video of how this works. So it's a system that's set up, basically attached to standard distal femoral resection guides, and that's how you register the center of rotation of the hip. It's a very simple maneuver, and then once that's registered, you dial in to the console the slope of your femoral, distal femoral resection, as well as the varus valgus angulation. And so in my practice, I've been using this mostly in complex deformities in patients. This is a 30-year-old gal that had unfortunately been hit by a car, had a multiligamentous injury, then had a valgus osteotomy which failed, but her alignment was gravely distorted by the osteotomy, and it didn't provide us with reliable landmarks that I felt would give me enough accuracy using standard instrumentation. She also had, you know, a lot of ligamentous laxities you'll see here on her preoperative exam. And so this was a patient that's 30 years old that I wanted to make sure we got the components exactly where we wanted them. And you can see here how much valgus she will go into with a stress. And so the accelerometry-based technology allows us to put the components where we want them and improve her alignment on a three-joint standing view very reliably. Here's another individual that had a very large deformity in two planes that needed a total knee arthroplasty, and you can see on post-op films we were able to achieve that not only in the coronal plane, improving his weight-bearing alignment, but also in the sagittal plane, which did require a little bit of femoral notching, but it did put the femoral component underneath his center of hip rotation. Finally, another case where we used this was someone that had had a previous malunion of a tibial shaft fracture from a blast injury, and you can see here there was no real reliable intramedullary or extramedullary landmarks that we could use, and the accelerometer allowed us to put the center of the knee above the center of the ankle mortise and allow him to have better biomechanics. And so I think that all this comes down to data. And so when you're comparing alignment using standard extramedullary instrumentation, you can see accelerometers usually get you within 2 degrees of neutral 95% of the time. Standard instruments in this study only accomplish that 68% of the time. So that's an A versus a D. So I'm a fan of A's. And then sagittal axis, you can see, also did much better. Also, more data on morbidity. Okay, they did Dopplers of the cerebral artery, and you can see that with standard IM instrumentation, there's a lot more embolic events occurring. A lot of people knock navigation because they say that it adds a lot of time. The study out of UC Davis showed it really does not add that much time. Additionally, you can bill for navigation, and so it's billable time spent in the operating room, which is also important. So in summary, I think accelerometer-based navigation provides us with a tool that allows for improved accuracy and fidelity of our cuts. It's extremely versatile. You can use it with any system you want. I believe that it's cost-effective if you're decreasing your revision burden, especially in younger, more complicated patients. Thank you. Thanks.
Thank you, you, Dr. Sassoon. So now I'd like to bring up Dr. Manner, who's going to discuss the cons about computer-assisted navigation.
Thanks. So here's my summary slide. That's basically what I think. Here are my disclosures. I have a MacBook and I have a Tesla, so I do know something about computer navigation since I let my car do it most of the time. So the declared advantages of computer-assisted surgery are the following. It restores patient anatomy. It enhances vision in a reduced visibility environment. It can address deformity and so on and so forth. And it presumably gives you some advantages in terms of accuracy. And I'm not going to necessarily argue with that because the data is actually fairly clear that navigation does in fact provide better alignment, at least in the frontal plane, than manually performed procedures. And in fact, the overall level of inaccuracy in the frontal plane is about 5 times less with a navigated system, and the number of outliers is dramatically lower, which is important. You want to be in the middle of this bell curve rather than out at the side. So I'm not really going to argue with that computer-assisted surgery can't make the X-rays look better and isn't reproducible. But what I am going to say is that none of this makes any difference. And when you look at implant survival, patient function, pain, satisfaction, there's absolutely no evidence that computer-assisted surgery helps. So to start with, does computer-assisted surgery improve implant survival? The answer is no. When you look at the data, what you find, this is a recent study from the Norwegian registry, they were similar due to overall. There were slightly fewer revisions for malalignment, but there was absolutely no statistical difference whatsoever. Mean operating time was about 13 minutes longer in computer-assisted surgery. Does it improve functional outcomes? Well, sort of. This is another recent study from Scandinavia. It was a randomized trial looking at a specific implant using a particular technique of measured resection. And what they found was that at 3 months follow-up, functional results were marginally better for the CAS group. At a year out, there was essentially no difference at all. One of the things that was interesting about this study is that they cited a, quote, slow recruitment rate. And in fact, over half the patients that were originally selected wound up being excluded for some reason or another. So, take this with a bucket of salt. Or not, actually. When you ask the patients, it doesn't seem to make a lot of difference at all. This is a study that was done recently using the same implant on both sides, bilateral procedures. So the first procedure was done with the computer. Second procedure was done with conventional system. And in fact, what they found was that 5 years, 15 of the 37 patients liked the conventional one better, 8 liked the computer-assisted one better, and the rest of them didn't care one way or the other. So part of the problem is that we can only measure a rather limited set of parameters with a computer. And what you find is that when you actually talk to the patients and find out how they're doing from a functional viewpoint, from a pain viewpoint, the data that you obtain at the time of surgery with a computer has essentially no bearing whatsoever on eventual outcome. And as this group stated or concluded, the intrinsic patient factors remain dominant in determining the outcome. So, what are my thoughts about using a computer to navigate around a knee? The first thing I would say is, number one, I don't need a GPS to get around my own neighborhood, and I would submit that if you need a computer to figure out how to put a knee in, you probably either aren't doing enough of them or you aren't doing it very well, and you might want to consider a refresher course. But the point is that you can make errors as a human. In order to really screw things up, you need a computer to do it. And the problem is that what you do with a computer depends almost entirely on the information that you input. Garbage in, garbage out, all right? And the problem is that we tend to look at this and go, well, we've put some garbage in, but it's on the computer, so it must be wonderful. So we have this idea of garbage in, gospel out, and that's simply not the case. So when you consider the expense, the added time, the added effort, the resources that you have to throw in, and then realize that at the end your results are no better, it's hard to argue that computer navigation is helping. Thanks.
Thank you, Dr. Manner. So now, if you'd like, we could take a minute to bring up any questions about computer-assisted navigation, if there's anything in the audience.
Question.
Yep.
So Dr. Sassoon spoke specifically about more in complex reconstruction, and I'm under the understanding that a lot of the studies that you presented, Dr. Manner, were more related to primary needs and a less complex setting. Is there any evidence looking at long-term outcomes in a complex patient as opposed to a standard primary?
So I don't think that data exists because the population is, Sure. The question was, is there long-term data supporting a benefit of computer navigation in complex primary arthroplasty patients? And I would say that data does not exist yet. And I think that, and the reason why I typically use it sparingly and in moderation in more complicated patients is just what Dr. Manner alluded to, is that we don't have good data showing long-term survivorship benefits of computer-navigated knees in the standard population yet. I don't think that data won't come to exist in the future, because I think that alignment is very important as it relates to survivorship. It just takes 10 years to develop that data. If you look at the Australian registry, it shows that since the use of computer navigation has increased within their data set, their revision rates have gone down in younger patient populations. So I think that data is coming. I don't think it's here yet. But for me, I think my specific use of navigation in complex patients is that, like Paul says, you don't need computer navigation to get around your own neighborhood. But when there's severe deformities, or there's going to be issues with the validity of your standard instruments and you want a secondary check, or you need to fine tune and dial in your correction rather than guessing at it, then I think that it makes a lot of sense to use, and it doesn't add a lot of time to the case.
Okay, so what I would say there is that,
Oh, you got one?
yeah, I think I'm hooked up, but, so what I would say to that is, first of all, you're probably never going to get a valid study that shows that, because, let's say, thank God my practice isn't like Adam's, but, he does 4 of these a day. But, the short answer is that the number of cases that you would have to do of, these weird and wonderfuls in order to demonstrate a significant difference, you'd have to do a couple hundred of them a year, and, thankfully we don't have to do that. But the short answer is that you could have gotten almost all this data that we got with the computer simply by getting a full-length X-ray of both lower extremities, which in fact is what Dr. Sassoon did. So he actually used a computer. He just used the computer up here in his own head to say, okay, well, I have to get it in this direction, I have to get it in this direction, I have to get this level of rotation. So since he's already done that in his head and with his hands, why does he need the computer to do it? That would be my answer. Okay. Any other questions before we move on?
Yeah, I'll have one question for Adam. So that case where that femur was notched by 30% or so, was that 25, whatever, was that a surprise to you, or is that the result that you had expected when you...
That was a compromise based on where the computer was telling me I needed to put the component based on the patient's sagittal deformity. And so the compromise there became accepting some notching, knowing that the guy's coronal alignment was going to preclude me from putting a stem in there, and also a compromise between flexion and extension, because if we flex the component where his bone was, he wouldn't be able to achieve terminal extension, and I know that wouldn't be a good result either. And so that's why I find that the computer navigation is helpful, because you can make a decision intraoperatively and adjust things based on what your eyes and your other tools are telling you. It's not like a custom specific block where you say, okay, I think I want this here, and then you're unable to make any changes to the plan intra-op. And so it allows you to work in real time to make those intraoperative decisions that are tough, but I think ultimately are important.
So in essence, it refined what your plan would have been even if you didn't have the navigation?
Yeah.
I guess I would say it the other way, which is you brought in a $100,000 implant and then did what you thought was best anyway. So what'd you need the $100,000
That's sort of the
device
point I was
for?
getting at,
Yeah.
but it
I
sounds
know, you're
like-
being nicer about it.
It sounds like it still helped you in the end.
But it wasn't, I mean,
refine
it's,
the position
it's,
and-
it's $850. It's not $100,000.
Yeah, but you wound up not paying attention to it anyway.
No, I used it and I compromised. So, you know, I think that first of all, I couldn't have got standard instruments up that guy's canal. So that was out of the question because there was no intramedullary canal for me to use for his femur. So it's not like I chose one or the other. I don't think standard instrumentation would have worked in that case.
Fair enough.
Yeah.
Yep.
This is a really interesting debate, and the idea of computer surgery is generating this whole world, and everybody's now developing all their patient specific. I'm interested in the process, never having tested these things myself. One economic question, though, is does the hospital reimbursement stay the same whether you use this technology or not? Or, in other words, is the DRG-based hospital reimbursement system the same for cases that have computer-assisted surgery?
My understanding is that you can submit the bill for however much you want, and they will give you the same amount that they were going to give you regardless.
So I'm not talking about the surgeon reimbursement.
No, I'm talking about the hospital. Yeah. I mean, particularly in the setting of bundled care, CMS is going to reimburse you what they think they ought to reimburse you. They're not going to care whether you use a computer or not. So.
Yeah, I would agree with Paul, but I would add one other thing to what I would add one other thing to what Dr. Mattson said. To me, the interesting question is, if Adam is right and long-term revision rates may be slightly decreased using navigation, and he might be, I think he made a compelling argument, there's no financial incentive. There's almost a penalty for us to worry about that intermediate to long-term result. And to me, it indicates that we're still not looking at the right, metrics when we get reimbursed for taking care of our patient, because all the incentives right now are to decrease the cost of care in the first 3 months, and nobody really cares after that. And so, slightly different topic, but I think that's what you were getting at.
Thank you. That was a good first discussion, and we'd like to move on to our second of three, and this is patient-specific instrumentation. And this is a process that's largely done preoperatively, as in comparison to what we just discussed, which is more so an intraoperative process. The patient-specific instrumentation that I'm discussing is something that was actually initially developed by oral surgeons to look at complex maxillofacial anatomy and was adapted to total knee arthroplasty. And the goal is similar to navigation. Try to increase the precision of the measurements that you can make so that you can provide the most mechanically stable extremity. The aims for this is an advantage of this can also be that, one, it can be a little less complex than the navigation, and that there's less of a learning curve, as well as there's less of a margin of error of actually utilizing the technology during surgery. And similar to navigation that Dr. Sassoon discussed, this is also something that can be beneficial for deformities, such as in a post-traumatic situation where an intramedullary guide isn't possible. So how does this work? There's a couple different types. There is this CT and MRI guided type, and there's also a patient-specific type for different genders and types of people. That's something also Dr. Manner is going to touch on. But in this case, a patient is scheduled for surgery and undergoes a preoperative CT scan or a preoperative MRI. And the data from the scans is inserted into a computer and a 3D reconstruction of the patient's anatomy with all of their deformities, osteophytes, mechanical, and anatomic axis is generated. Once this is done, the computer, as well in collaboration with a device company and the surgeon themselves, is able to determine where the appropriate cuts, as well as the positioning and sizing of implants should be at. Once there's final approval by the surgeon, a company can produce 3D printed cutting guides for the tibia as well as for the femur which is specific for this particular patient. So it matches the patient's anatomy and is able to be put onto the patient intraoperatively using their own deformities and anatomy and create the cuts that are necessary. So these cutting guides that were 3D printed are taken to the operating room with the surgeon and used for the case. Again, a typical approach to the knee is done, and these guides often have cues, visual cues on them, certain tabs on the cutting guides that will allow the surgeon to have a visual an acknowledgement that they are in the appropriate location intraoperatively, and the surgeon is then able to make the cuts. And an advantage is after that is that since this was all templated preoperatively, it allows the surgeon to have more precision in the selection of the size and position of the components. So that's a brief overview of this type of CT and MRI guided navigation and patient-specific instrumentation. I would like now to bring up Dr. Manner, who's going to discuss his insights as well as the pros for this.
Okay. Thanks. Now I'm pro. Okay. So, and Dr. Sassoon's going to be anti. So, we can switch. And in fact, we could even switch our own notes, and Adam can do this talk, and I'll do the other one. But so I'd like to start off by saying basically, hooray for patient-specific implants. And the reason I say that is that we talk a lot about how great total knees are, and we look at the literature, and the numbers are wonderful. 90% survival at 15 years. Even with old-style implants such as the insult bursting, we see survival of up to 90% at 15 years. And in point of fact, most patients will wear out before their knee does. The problem is that focusing on implant survival is misleading. And I think we've often done a rather poor job of focusing on outcomes that matter to patients, such as pain, function, overall quality of life after surgery. Our objective measures tend to be things that we can look at easily. So things like range of motion, stability, and even there, to be honest, I think we are, perhaps we should say, a little bit overly optimistic. So let's look at this here. This church is a success. It has not been revised. It's well aligned, and its range of motion is excellent. I will grant you that there is some wear, but overall, if we're using the same criteria that we use for implants, this church is a rousing success. Does anybody think that this is really successful? And the answer, of course, is no. So what do patients want? What they want is they want to be able to do what they were doing before their knee hurt. And that's not what they get. Even if they do get some improvement, the fact is that they do not become as functional or as pain-free as their age-related cohort that have not had a total knee replacement. And the fact is the total knees of today are not nearly as good as we pretend that they are. Patients are not as satisfied, patients are not as active, and the typical total knee does not behave like a normal knee is supposed to, so it's not surprising that patients keep disagreeing with us on the relative success of their implant. And part of this has to do with implant design, because even modern implants often don't fit right. They're hard to put in correctly, and in fact, when you look at how patients are doing, survival of the implant without a revision, no loss to follow-up, good pain scores, good function scores, the fact of the matter is that by 6 years out, only about 50% of patients are what we would really should call a success. So what have we tried? Well, we've tried more sizes. We've tried better polyethylene. We've tried better alignment techniques. We have better tools to measure soft tissue tension. We have different designs. We've looked at pain management. We've looked at post-op rehabilitation. We've looked at pre-op rehabilitation. And the fact is that none of these have really done very much. We just talked about navigation. And theoretically, it is more accurate. And you have this ability to confirm placement. But the fact of the matter is that it reduces outliers. It doesn't eliminate them. It's costly. And only very few papers show any clinical benefit whatsoever. What about pre-navigated jigs? And this is a variety. Stuart showed a few of these before. The problem and the theory is that they're disposable, so they're cost-effective, they're fast, and they're accurate, but unfortunately, as with everything else, nothing spoils good results like follow-up. And what you find is that they are, in fact, no better at putting the implants in, and they are questionably time-saving and cost-effective. And the biggest problem with patient-specific instrumentation and patient-specific blocks is that the implants are still the same. So you can have any car you want as long as it's black and as long as it's a Model T. Instrumentation is not going to make things better. We need a better implant. One of the problems that we see with total knees in general is that there's a substantial amount of variation between patients. This is a picture of Wilt Chamberlain, he's the tall guy, and Willie Shoemaker, who's the short guy. And Wilt the Stilt was 7'1", weighed 275 pounds when he was playing. Willie Shoemaker was 4'11" and weighed 95 pounds. And so there's a fair amount of variation here, and having a few extra sizes on the top and the bottom probably isn't going to do very much. What about sex/gender? Well, amazingly enough, these are different people. And when we look at males versus females, there is a distinct dichotomy. And I'm going to go out on a politically incorrect limb here, and I am going to say categorically that men and women are different. How are they different? First of all, men tend to have a larger anterior condylar prominence. And when you put a standard implant into there, what you're going to wind up with is an overstuffing of the typical female knee. In addition, women have a slightly higher Q angle, or a slightly more valgus angle, and the reason for that is that on average, the female pelvis is slightly wider. And then lastly, women tend to have a modified or different ratio between the front to back versus the side to side ratio. And typically what you find is that female femurs have a more trapezoidal shape. They are slightly narrower side to side for a comparable front to back dimension. And as a result, if you take the same implant and put that into a woman's knee, it's going to overhang. So why patient-specific implants? Basically because one shape and a few different sizes are not going to meet all needs. It's not going to happen on the femur, and it's not going to happen on the tibia. When you look at a standard tibial component, what you find is that it fits about 2/3 of the tibial surface. There's either overhang in the back or there's under coverage in the front. When you use a customized implant that's actually shaped for the patient, you can get close to 100% coverage. And that does a few things. First of all, it allows better reproduction of normal motion, and it eliminates, or almost eliminates, side-to-side laxity. So the knee is going to feel more like a normal knee. So the advantage of patient-specific implants is that because you can shape the implant to fit the patient rather than shaping the patient to fit the implant, you're going to get something that feels more like a normal knee. The patient is going to feel more like the knee behaves properly. And as a philosophical point, if we don't believe in one-size-fits-all for media or an electronic medical record, why would we think so for people? So a little bit of final philosophy. Every endeavor goes through a certain set of steps. And it starts out by being an art where learned experts, such as us, expound on how difficult it is to do everything properly. And then eventually you got on to having some rules and some instruments on how you do it. Eventually you come up with standardized procedures and templates, which I think is where we are today. What we really need to do is we need to take the next few steps, and we need to integrate computers effectively, and we need to automate the process as much as possible so that we get rid of the variation that occurs when we start fiddling around in the operating room. Thanks.
Thank you, Dr. Manner. Now I'd like to bring up Dr. Sassoon, who's going to discuss the other end of this and the cons.
I guess I was confused. I didn't know we were doing gender-specific knee debate today.
You can do that too.
But I'll try and touch on that at the end. But As it relates to patient-specific instrumentation, I'm sort of opposed to its routine use, and I think it has a very narrow role, as we'll see here. But what we know about patient-specific instrumentation, okay, is it requires an extra advanced imaging scan. It has increased cost of care delivery. And what's the trade-off there for that technology? Well, the anticipated pros would be that it would potentially improve alignment, improve reproducibility, hopefully improve outcomes, improve efficiency in the operating room. But what does the data actually say? So this is not a question that was new to me. So I have evaluated this based on a systematic review of the literature, and the things that we need to think about are really threefold. One, does patient-specific instrumentation more reliably lead to a neutral alignment? Does it make surgery more efficient? And does it lead to improved clinical results? So in performing a systematic review, we looked at all of these outcome measures, and these are the studies that we included in this review, varying from level 1 evidence to level 3 evidence. And, well, here's what it says on alignment. So the 3 level 1 studies, there's no difference in alignment based on traditional instrumentation versus patient-specific instrumentation. And I will just sort of reflect back on the last topic, which showed a significant difference between computer navigation and standard instrumentation. We're not seeing that with patient-specific instrumentation, okay? So the level 2 and 3 studies also failed to show significant difference in the majority of instances. OR efficiency. So we looked at this as it relates to 3 questions. OR time, number of trays opened, and the accuracy of the surgical plan that's involved when you get a custom-specific jig, because it's not open to intraoperative real-time decisions. You get a jig, you put it on a femur or a tibia, and that's it. And if it doesn't fit or if it looks funny, you're kind of hosed. So the 3 level 1 studies that evaluated this, there was one showed no difference, one showed improvement by 5 minutes, and one showed improvement by 7 minutes, which isn't really a significant difference. And there was mixed results in level 2 and 3 studies, but certainly no trend showing improved OR time. Less surgical trays. Well, the literature does show that patient-specific instrumentation does lead to opening fewer trays. That's awesome. Accuracy of surgical plan, which I think may be the most important. Okay, so 4 of 5 level 2 and 3 studies that evaluated this question show there were significant discrepancies between the jigs and the preoperative plan. And then also when it was checked against computer navigation, there was a lot of inaccuracies. So I think that's really important too. So if you're going to spend the money, you want to be getting something that's reliable and that's going to lead to improved outcomes, and we're not seeing that. And then in terms of the clinical performance of patients that have had patient-specific instrumentation, there is really limited data on this, but in the 2 studies that were evaluated, there was no difference in these sort of standard outcome studies. So more recently, there's been another level 1 study that came out since I published this review, but basically this was a randomized controlled trial, and it showed no reduction in outliers, no improvement of alignment, no improvement of Oxford knee scores or SF-12 scores. So the authors here concluded that there's no support for the routine use of patient-specific instrumentation. So to recap, known cons: extra scan, higher cost of care delivery, increased second guessing in the operating room. Known pros: less trays. You decide. So when would I use it? So this is a patient that had a nail placed to treat prophylactically to treat a tumor lesion in their femur. They've gone on to cure their cancer, but they're very attached to this nail. They don't want to take it out, and this patient wants a uni. So currently there's no accelerometer-based system for unique compartmental knee arthroplasty, and there is some custom specific patient instrumentation. So I'll probably use that because I can't use standard instrumentation with that nail in place that this guy's unwilling to part with. So this is a very, very limited clinical indication, but just like lots of technology out there, it's a tool. It's good to be familiar with it and have it as part your repertoire. So thank you.
Thank you, Dr. Sassoon. If you two can come back up, we'll take a moment for questions before moving on to our final topic.
Great presentation. I think one thing that you both mentioned is in cases of deformity, navigation, whether it's computer navigation or pre-navigation with PSI can be helpful. But with the knee, assuming that you have a set soft tissue compliance of a given knee, the collateral ligaments especially, what are your guidelines on accepting whether you're going to be able to correct deformity through the knee with your implant position versus extra-articular correction of the deformity through osteotomy? So what are your guidelines?
Yes. So I think that's a very important point. So I think, you know, we like to think about total knee arthroplasty as a bony operation, but it's also very much a soft tissue operation, just like, you know, total shoulder arthroplasty. But I think that it's important to keep in mind that there are two separate questions. So you want the components to be in alignment that's neutral relative to a mechanical axis of weight bearing. The soft tissue balancing around the knee becomes sort of a secondary question, and that you have to answer separately. So once I have the components where I want them, I then would make releases either to the medial collateral ligament or lateral, you know, collateral or IT band or whatever to balance the knee, in addition to increasing my poly size. And that happens after I have the bony resections performed such that it establishes a neutral mechanical alignment. I think in situations where you have severe deformity, where you have to sort of compromise because maybe making a cut that's perpendicular to your mechanical axis in the tibia is going to greatly destabilize the lateral compartment or the lateral soft tissue structures in the knee, that's when I feel that navigation sort of wins this fight, because that's where you can sort of change the plan or decide ahead of time that maybe I'm going to leave my tibial component in 2 degrees of varus, which I think would be acceptable as not falling into an outlier sort of category, and yet not be so devastating to the soft tissue balancing question. And so a lot of that does involve, you know, thought ahead of time and careful planning, but it's nice to have something that you can, a technology that allows you to make those decisions in real time. Does that answer your question? Kind of?
It does. It does, but oftentimes you're not in that envelope. And that's my point. And I think one of the huge benefits you have in this training program is your ability to look at deformity and be able to do deformity correction where it can get you in the range where you can then proceed with arthroplasty and ligament balancing. But I've seen some disasters of trying to correct too much deformity in the intra-articular portion of a joint.
Sure.
So that was just my point.
Yeah, sure.
Nothing to add.
Yeah, my follow-up question was very similar, and it was going back to that case again. No criticism at all, that case with that. No, honestly. I mean, that's just a brutally hard case. But I wonder, you know, if that was an example where a preoperative osteotomy just would have, you know, as a separate procedure, sometimes you can combine them, would have yielded something that was, in the end, you know, better, and you wouldn't have been reliant on the navigation. And again, it's you know, just one point about one case. But in general, I think we can't forget that there is a role for other procedures to help us get to the end result of an arthroplasty.
I think it's also important to remember that, you know, patients have to be involved in their own care
Yeah.
decision-making process, and also sometimes extra procedures do come with their own set of risks and benefits, and
Yeah,
so.
yeah, and I think we all know anytime you touch a joint, I think you're putting it at a higher risk for infection with the next procedure.
Okay, thank you. That was great. So we'll move on to our final topic, which is remote monitoring. This is something that's done post-operatively. And in an interest in time, I'm going to quickly provide an overview so we can get straight to our debaters. So traditionally in total knee, as well as total hip arthroplasty, the surgery is accompanied by hospitalization as well as some pretty intense rehab. But with improved technology and improved procedures, there's been a movement towards shorter hospitalizations and in some cases even essentially an outpatient surgery, which has spurred this research in developing ways to monitor patients while they're doing their therapy at home. So what this is this remote monitoring program. Patients are enrolled and undergo the surgeon's total knee or total hip arthroplasty of choice, and then the patient undergoes a short or sometimes even no hospital stay before going home and performing a self-guided home rehabilitation exercise program. There's a clinician at a remote site who is able to monitor data taken from the patient during their rehabilitation, and using that data can assess how they're doing, provide education, as well as intervene if necessary. And also, this also allows the surgeon to have almost real-time information about how the patient is doing at home with their activities from a day-to-day basis. So how do we achieve the remote monitoring? The technology has evolved over time. Initially, it simply was sticking a video camera at home and watching the patient over a monitor as they're doing their activity. But we've been able to develop more elegant solutions for this technology, including remote sensors that are attached to the patient, as well as pedometers and pressure sensors that are in the patient's feet and their shoes. And using this technology, we are able to evaluate different metrics of the patient's rehab, including their range of motion, cadence, even the pressure that they're putting on the ground as they're walking, and of course using a pedometer, how many steps they're able to take while they're walking through their home. All of this information is able to be integrated into an interface that the clinician is able to see to provide their evaluation. In addition, this interface is also available to the patient so that they have an idea themselves of how they're doing as they're performing their exercises. So as an example, if a patient is working on range of motion exercises, they are able to see right in front of them what the range of motion is, as well as get an idea as to where they are compared to where they should be, which can be used as a motivational tool. So this is a quick overview of how this works, and now I'd like to bring up Dr. Manner, who's going to provide his insight and discuss the pros of remote monitoring.
Thanks. This is a little bit of an opportunity to describe kind of what we've been doing here at UW in the last few years. And this is essentially Big Brother is watching you. And just to give you my disclosures, I co-founded Own Equity and serve as the Chief Medical Officer for Joint Metrics Medical, which is a startup from here, which has partially been bought out by Zimmer. So here's what we say. Here's what the patients say. It's not doing as well as we thought. And it's pretty clear that what we think does not correlate with what patients think. And again, what patients want, they want to do what they were doing before their knee hurt. That doesn't happen. Kind of going through a little bit of this. So the question is, why are our results so bad? And there are a few issues here. First is patient selection, implant design. Bad implants do worse. Surgical error certainly contributes. Poor pain management and lasting muscle injury. And I would say we've concentrated a lot on numbers 1 and 2, less so on number 3, and not at all on the last 2. So it's clearly easier to put implants in straight with an exposure like this. The problem is that there's a trade-off between good exposure and lasting injury to the muscle sleeve around the knee. And traditional exposures cause lasting muscle injury with substantial short and long-term sequelae. This is a CT cross-section of a 70-year-old female who's a year out from a total knee replacement. And what you can see is that the quad is persistently atrophic, okay, particularly the VMO. And scarring with resultant stiffness occurs more often than we like to think. So range of motion does make a difference in terms of activity, and that's a reason that it's important to check. But the problem is that we don't know what patients are doing after they've left the hospital, and we don't know how to make their rehab effective. And as a result, what we should be concentrating on, particularly because our hospital stays are now 2 days or less, so we need to be concentrating on the other 88 days of that global period. So just as a little bit of a background, this is based on technology that was developed by Peter Cavanaugh for NASA. And the original iteration for this was to assess what astronauts were doing in space and quantify the relationship between lack of gravity, lack of force, and the rate of atrophy of the musculoskeletal system. Now, it's easy when you're doing this with an astronaut, because an astronaut, you know, it costs $1 billion to send them up into space, or 100 million, or whatever it is. Anyway, it's a lot. So if you tell them they got to put this thing on and use this every day, they're going to do it. Unfortunately, I would say the technology's gotten a little bit easier to manage. And we've taken the NASA system and made it a little bit smaller. And in fact, actually, that's too bulky. This is what it looks like now. So this is the latest iteration of our design. And what we're doing here is we're using a machine learning algorithm to decipher what the patient's doing based on angle measurement in space and the speed of motion. And we can identify up to 17 discrete activities, but we only need about 5 or 6 of them because that's what patients typically do. So this shows us teaching the machine how to think, and then shows whether the machine can learn. And what we find is that we can get this about 96 to 98% accurate. So how does this apply to a patient? This is some raw data from a patient at 2 different time points. And she's undergone a bilateral total knee. The top section is at 10 days, and the second section is at about 21 days. Don't worry, this is what the machine sees. You don't have to decipher this. But this is the data distilled down. In the first instance, she's 10 days out. She's kind of scuttling about. She's not really doing a whole lot. By 2 weeks later, her extension is better, so is her flexion. She's more active. And when we sort of look at a graphic explanation, what you can see here in the first trial is that she's spending most of her time lying down or sitting. By 2 weeks later, she's exercising, she's walking, she's climbing stairs. And we can compare data across patients. They're all doing pretty well in achieving extension. But flexion is apparently problematic for patients 1 and 3. And what we found out from this is that both of them stopped exercising. And as a result, as you would expect, their results didn't do so well. The other thing that we can do is we can look at how patients are doing compared to each other. And what you find here is that initially both patients were doing okay. And the patient A had about 120 degrees of flexion. Patient B had 135 degrees of flexion. But when you look at what they're actually doing, what you find is that the second patient, who theoretically was better because they had better range of motion, they actually weren't doing very much. Well, you can also decipher whether patients are confident in their walking. What you see here is that patient A has resumed a normal walking pattern, whereas the second patient sort of started out okay, but really never got very far. And again, the reason for this is that the patient didn't exercise. We would not have known about this until 90 days out. With remote monitoring, we can tell right away, and we can either get on the phone or get in contact with the patient somehow and tell them, get back to physical therapy. So what remote monitoring does is it allows full-day assessments in the patient's native environment. We can look at the patients in the wild. We don't have to bring them into the zoo and watch them in the clinic. And it allows us to do real-time objective measurement. So one of the questions that we always have is, will patients accept this? And the answer is that patients, in fact, are actually very comfortable with remote monitoring, and in many ways, they're way ahead of us. And this goes along with the popularity of electronic fitness products. So in some ways, we always talk about how awful medicine is, and people have been talking about how awful medicine is for the last 1,000 years, but the fact is that in some ways we're very lucky, because we are at a point where we have a lot of different trends converging at once. We have smartphones that can do more than any computer ever could 10 years ago. We have cloud-based computing. We have an increased emphasis on patient-centered outcomes. And some of this is going to be forced on us because basically we are being told this is what you have to concentrate on, and it is no longer an optional measure. Telemedicine is part of being an accountable care organization, and it is part of the future of medicine. So the fundamental reason to do a total joint is to eliminate pain and restore function, and until now we really haven't measured that. So just want to thank my coworkers and the fact that the folks that funded us. Thanks.
Thank you, Dr. Manner. And finally, I'd like to bring up Dr. Sassoon, who's going to give his insight on the cons.
First, I want to just congratulate Paul and Dr. Kavanaugh on the development of that. It's a very awesome tool to use, and I think it probably has a great place in conducting research in following total knee arthroplasty. And the position I'm taking in today's debate is that I'm stating that I don't feel that remote monitoring of TK with procedure-specific devices has a place in routine post-op clinical care. And I think that the data that I have to support that is really a sort of economic data. So the rates of primary total knee arthroplasty have tripled between 1990 and 2002, and they continue to grow. This is a huge economic burden. Total knee arthroplasty is the #1 procedure paid for by CMS, and as Paul's alluded to, healthcare economics and bundled care is becoming a substantial part of our dialogue in terms of how we provide population-based care. So first question is, who's going to pay for a device that has not been proven to reliably improve results yet? And can we focus on other affordable means to improve our outcomes? So I think the chief question comes down to, how do we judge our success in total knee arthroplasty? And typically we do that by checking patients' range of motion in clinic. So I would submit to you, I don't think Paul is using these devices in his clinic when patients come to see him to check their range of motion. I think he's relying on his eyes and his PA's eyes. And so I don't think we need to rely on anything else in a remote setting, and I'll show you why in a minute. Also, PT progress notes often get sent to us, and to be honest, a lot of times we don't read through them with a fine-tooth comb. I don't know that I'd be poring over countless hours and minutes of each of my patients' daily routine, to use the vast amount of data that this instrument would provide to dictate my clinical care. And then I think the other way we judge success is patient-reported outcomes. I think this is probably the most important tool that we have currently, and that's because it tells us subjectively, do patients actually like the total joints that we're putting in them? And this is what's being used by CMS to judge our success, which is also important. So here's the Coos Junior form, and so these are subjective questions that patients answer, and it's dependent on patient expectations and their preoperative function. So a lot of that is going to be extremely variable, and I think that when we have patients that have different expectations, having raw numerical data doesn't really tell us the whole picture. So, this is a guy that I revised who had an extensor mechanism disruption at the time of his revision surgery, and this is a video that I took in clinic, but it reliably shows that he doesn't have an extension lag. He's got good function at 3 months, and you'll see shortly that I'll be able to assess his gait. These are the tools that we use in clinic. We can use these tools remotely just as easily by having patients take a picture or a video with their smartphones and send it in. And that's technology that most people have at their disposal in their pocket at all times. And so I don't know that we need new devices over smartphones. These are all examples of technology that have been eclipsed by smartphones. I don't know anyone that has a Garmin in their car anymore. Well, I can tell you that people don't wear watches as much anymore, even the graphing calculators, things like that. These are all things a smartphone can do, just like they can take pictures and send movies. So, if we have videos of patients preoperatively and we know what their function is before we operate on them, and then they send us remote correspondence either via pictures or simple video footage of them walking, we're going to know if they're doing well or not. We don't need 24 hours of range of motion data to know that. And so the other thing I would submit is that patient satisfaction is often disconnected from range of motion. So, here's a lady that wanted to get back to yoga after a total knee. She's got great range of motion. She's very satisfied with her range of motion. Here's a 90-year-old that had a revision surgery who has much more limited range of motion, but she is also extremely happy with her knee, given her circumstances and her functional level. So I think that, again, this is where raw data wouldn't really tell us what's going on with these patients. So I think rather than trying to accumulate more vast amounts of data post-operatively, we should be spending our time pre-operatively in really understanding patient expectations and modulating these expectations so that patients get more satisfaction rather than relying on sort of cold, raw data that doesn't really tell a story. And so I think, in summary, from all the things I've talked about today, I think the take-home points are alignment's important, cost is important, and patient education and expectation, understanding and modulation is important. So thanks so much. Yeah.
Due to time, we're going to have to let Dr. Sassoon get in the last word on that topic. And by the way, that allograft reconstruction of that extensor mechanism, those are not supposed to work. That's actually an amazing result. I just wanted to remind everybody that I asked these guys to sort of go after each other, and they had a lot of fun putting this together, and I know they tried to make it a little controversial, so I appreciate that. And for me, the take-home message is total knees really work well, and if there's 96% survival at 15 years, it's going to be really hard to make that a lot better and to save money, and that's probably why CMS is doing things like penalizing us for having DVTs and infections and things that if we follow all the protocols, we really don't have any control over. And so maybe the hope is people like Paul, who have about 20 years of experience and many, many thousands of joints, and Adam, who I think we all know has taken on sort of all the disasters from within the department and around King County at this point. So thanks to everybody, including Stuart, for putting it together. Thank you. Yeah, that was great. I mean, I kind of had to send you guys.